Welcome to the CMHT QI Podcast. My name is Dr. Hassan Mallick. I'm in ST4 at the time of this recording. And thank you for listening to this episode. We're talking about an induction to North Kensington CMHT in particular, but I'm hoping that these things can also be branched out to whatever CMHT you might be working in. For today, I'm going to talk to a unique service and a new service, and to talk about that in particular, there's my colleague. Her name is Josie Geddes. You want to say hi, Josie?
Hi.
Tell me a little bit about what your role is. What are you called?
So I'm a complex emotional needs clinician. I work in North Kensington and Chelsea CMHT, and I'm part of a new team. It only consists of 3 of us, as my manager Sally, and my colleague Tanya, who is an advanced lived experience practitioner. And we started about a year ago, and we make up the complex emotional needs pathway team.
So tell me about complex emotional needs. What is that, and what kind of demographic do you work with?
So complex emotional needs has kind of, like I said, only set up in the last year and was part of the transformation. And thankfully, CNWL recognised that the needs of people with complex emotional needs, which other people may kind of refer to as people with emotionally unstable personality disorder, was not really being kind of met within either primary or secondary care. And as part of that recognition, this team has been set up to offer intervention support to teams and treatment to patients to better meet the needs of this population.
You mentioned a couple of things. First of all, I'm glad you're part of that changing narrative about personality disorders. I think there are generally good intentions, but unfortunately the language and the lingo still needs some updating. So you mentioned transformation. What is that?
So the transformation was, I think it happened across most NHS, I think, trusts, and people were asked to think about changes that they felt would be useful to meet the needs of the kind of, the population of people they work with. Mm-hmm. And different trusts decided to do different things. And CNWL decided that, among other things, part of their transformation was going to be including a pathway for people with complex emotional needs. And a big part of it is not only treating patients, but also educating, supervising and supporting staff to better understand the complexities that come with this population, and strategies and ideas about how to have kind of effective working relationships, and also how to access support when challenges arise. And that's what we're here for.
Yeah, I hear that word a lot, like coming new to the trust as well as London. I assume it's a trust thing. So what I understand about it is more like a restructuring of the services to meet the needs that there are, and a lot of it specifically for your service or your patient demographic. So my supervisor at this time, Dr. Yasna. So she's done like a PhD in personality disorders, and she is in the CMHT, and she was talking about these like audits that different trainees have done, which shows how many people approach a CMHT. Their first presentation has something to do with either suspected personality disorder, either they themselves feel or their loved ones feel, or so there is a huge, I hope it's the right word, huge demand to understand that, both I think internally for health professionals, and I personally think it's still like a growing process. We're still understanding it. There's new research. I think the new NICE guidelines were published last year, or they have been very recently over the past few months been published. So definitely a lot of people do come in with under the complex emotional needs bracket. What's your workflow like? Like we talked a little bit about there's a lot of demand, but then how busy, or I don't know if there's a non-busy word in the NHS lingo, but what's an average day like for you?
So generally, my morning starts every day with an MDT. So sitting within the hub, which I really enjoy. And the hub was part of the transformation. So we've moved from a CMHT community mental health team to a community mental health hub, which means that we've got more teams that come together to think about patients and work alongside one another. So the morning starts thinking about patients, and that I feel I've come from primary care, so I feel lucky to have that, where you've got lots of different minds thinking about a patient, and they will have their own kind of way of approaching difficulty. So that's how we start the day. I do assessments for people that have been referred into the CEN, complex emotional needs pathway, and then think with my team about treatment. I attend Therapies hub meetings where I think with psychotherapy, psychology, arts therapies, and IAPT about the best treatment interventions for patients. I offer an MBT group, so I lead an MBT group along with my colleague, and we do that once a week. That's a year-long intervention. I do one-to-ones with half of the people that attend that group, working on mentalization, formulation, and kind of focusing on improving their mentalizing in one-to-ones alongside the group. I do a psych ed group, so that's one of the first interventions we offer. I do SPS, which is structured psychological support. That's the only one-to-one offer that we have for patients with complex emotional needs. I'm also an EMDR clinician, so I offer EMDR sessions. I see a patient once a week for that. I do a complex case forum, so I provide that to support patient staff to come and talk about any complex cases that they have, or themes that come up working with this population, challenges they may have faced in the past, a space to just come and think with other staff about complex emotional needs. I have quite a lot of supervision, and I'm available to support staff all the time to think about complex patients that they're working with, and attend lots of meetings and professional meetings, and yeah.
Wow. Okay. A busy lady. But I like that. I feel like what I understood from that was that you do assessments slash management, where you're actually working with a service user or patient. You also do group work, whether it's within your own team internally with other health professionals, but also with service users as well. And you have, I think, you have pretty much the whole alphabet in terms of therapies you offer. So multiple therapy modalities, as well as your own supervision and personal growth. Do you think that kind of encapsulates it a bit?
Yes.
One of the ideas of this podcast is also just to show a bit more about the personal or human side. So I think just for the listener, one of the patients that we worked together with was someone who was offered a new diagnosis of complex emotional needs, or EUPD. They actually were a rarity, I feel, where they actually thought they did have it and they wanted a diagnosis, and they're like, okay, doc, what do you think? So I think for me, who's still a trainee and still learning, so it was, I think, your expertise and input, both in terms of guiding that, okay, this is what I'm thinking, this is what they presented with, this is the history, as well as downright, we shared a review together where we both talked to this individual, whether offering pharmacological or acute, should I call it containment therapy? Tell me a little bit about that emergency kind of service that you offer as well.
So there's lots of different ways we can think about what would be helpful for patients at different times in their presentation. And I think that we had felt, particularly with this person, that their presentation was kind of a bit more panic and anxiety based, and actually they would actually benefit from having a brief focused intervention to better understand that difficulty and develop some skills for managing it. And often, I mean, we're under a CEN pathway, and the pathway means that people can move through different treatments. So it's not just one offer. We might do the psych ed group, and then we might offer MBT. They might do a brief intervention with psychology, and then we might think about offering them something else. So we recognise that there may be a few things that this person would benefit from having, a few interventions.
With all of the services that you have to offer and all of the work you do in a given day, what is your caseload, or how are people added to it? what I'm trying to ask is that how do I refer someone to you?
So they'll come through the Therapies hub, and there are kind of particular criteria that I'm looking and listening for during the hub discussion. The thing is that people need to have either a diagnosis of EUPD or identify with having complex emotional needs. There's a flow chart that we created. I don't know if there's a way for me to kind of provide a link along with this podcast, which I'd be more than happy to, but it shows the kind of pathway through the complex emotional needs and the different levels. So just because somebody has complex emotional needs or EUPD doesn't mean that they're always in crisis. I think that sometimes people hear EUPD think, right, we need to be offering them the most intensive treatment. We don't. So we can review where they're at different stages. People have complex emotional needs, but actually the risk isn't too high. Psychology can see them. When they come under my pathway is when we're noticing actually there's regular presentations to A&E or calls to our duty team. There's maybe been a recent attempt on their life, kind of ongoing deliberate self-harm, risk of harm to others. That's when they're more suited for my team. When it's incredibly intense and there's kind of like hard to engage, really risky behavior, then we're thinking about the water view, which is a kind of a much more intensive, specialized service for the treatment of EUPD. So for me, we're looking for emotional dysregulation, interpersonal difficulties, current risk, severe risk, maybe a history of treatments that they've tried and actually it doesn't seem to have been helpful. They're the kind of general things that I'm looking for.
So can you tell me about the number of patients that are open to you at any given time or on average? Is there a number on your caseload?
I don't really have a caseload as such. I mean, the people I do one-to-ones with or EMDR with or SPS with, 10, 15 people I've done an assessment with.
Maybe a more fairer question would be, what are the different lengths of treatment that you offer? For example, I know you do a short acute thing for a couple of weeks, but then there's also like EMDR, I think it's relative and it's dependent. It's on the kind of the presentation. So we offer SPS. Typically people would be seen for up to 10 sessions for SPS. It's brief and it's focused. The MBT group is a year. A nice long offer of treatment, and alongside that having the one-to-one. So again, both of that for a year. EMDR, like I said, is kind of dependent, so it could be up to 6 months, but it depends how people respond to it. And then the psych ed group is 11 weeks. Okay, and just to clarify, MBT is mentalization-based therapy and SPS is
structured psychological support. It's the only one-to-one intervention that we offer. The evidence tells us that group work is much more effective for complex emotional needs.
Is there any patients you work with who do not have a diagnosis of complex emotional needs?
Yes, for sure. As long as people identify with it, they don't have to have the diagnosis. As long as they identify with the kind of the key features, which is this kind of emotional dysregulation and feeling incredibly distressed and not quite knowing how to regulate or navigate that, interpersonal difficulties, so just finding it difficult to build and maintain relationships, and risk.
I'm having another episode of the show with Doreen from psychology, so I'll ask her as well. But I think unfortunately, kind of the stereotype of psychological services or therapy has also become that there's long waiting lists. So can you talk a little bit about, obviously depends on the presentation, of course, but generally from first hearing about a patient to seeing them or offering them therapy, what's the gap like? What's the turnover like?
So I'll let Doreen talk to you about psychology. Their weights are quite different to ours.
Yeah.
We're quite lucky at this point. We're a year in, and we're running our psych ed group frequently. So I think we're running the 4th or the 5th round of it, and we've been going for a year. So we're running it a lot. That means that we're able to offer people something fairly soon. So from the case being brought to the Therapies hub, I'm generally able to offer an assessment within about a month. Maybe 5 weeks might be the most that somebody waits for an assessment with me from being discussed in the Therapies hubs. That's actually not too long. It could be quicker than that. And then from then, the general first offer we're thinking about is the psych ed group. It's a group that runs for 11 weeks. So if you think every 3 to 4 months we're running it. So generally people could be waiting another 3 or 4 months to then start the psych ed group with us. So not too long in the scheme of secondary care offers.
Yeah, I'm sorry that was kind of a difficult question, but I think it's not. It's common news these days. Whenever you open the television about long waiting lines, everything from, unfortunately, cancer assessments all the way to GP services. So, I think part of that, what I personally think that with patients, it's not necessarily the waiting time. It could be, but it's also the ambiguity. So they do benefit with saying that, okay, it's going to take a month, but you'll be assessed, okay, and then we'll see. Then we might offer it, or these are the realistic timelines we are working with, rather than say soon.
Yeah.
So that's
Yeah.
like, well, what do you mean soon? Is it tomorrow? Is it a year later? So
Because my soon might not be your soon.
yes.
Yeah.
Okay, so thank you for that. Tell me, just going back to something you said way at the beginning. You talked about expert by experience. Can tell me what that is, or I
Yes.
think CNWL, our trust in particular, is kind of renowned. I hope that's a good word. Is kind of renowned for it, but just for someone who doesn't know, what is an expert by experience?
So Tanya is the current advanced lived experience practitioner, and that means somebody who has a lived experience of mental health difficulties and treatment within the NHS and could be outside of the NHS. And what that does is it allows co-production. So it allows us as clinicians to have a better understanding of what it's like to be on the other side. So the decisions that we make are always made together. Any material that we produce, we're always thinking together. What Tanya is able to do incredibly well, she has a knowledge that's kind of definitely superior to mine, is she can offer her perspective of what it might be like to hear that, what it might be like to experience that. She's good, gosh, if I put my patient hat on, and she's able to help us to think about something from a different perspective, which is incredibly helpful. And again, like we've said, everything that we're doing within the SEN pathway is co-produced. So Tanya and I and Sally, we work together. And that's something for me to have got used to, which is, I used to work in primary care. You're very much on your own. You're a kind of very independent clinician and you kind of get on with it. This is very different. You're constantly working together with somebody else to form whatever it is that you're putting out or decisions that you're making based on, she has a very different set of eyes and perspective that's incredibly important to inform what we do.
Is this a new concept?
It's a good question. So I'm not 100% sure. So I've been in secondary care for about a year. My understanding is this is a new venture. Also, I think what's important is that we're at the same banding. So that I think that's fairly new, that advanced lived experience practitioners are valued and paid accordingly, that actually we recognise that what you have to offer is incredibly valuable and worthwhile, and we pay you appropriately. I think that's quite new. Yes, my understanding is this is quite a new one. I think it's existed in other forms for a long time, but I think it's quite a novel idea for us to be picking that up and progressing with it.
I mean, not the domain of today's episode or this QI project, but I think it kind of reflects the overall changing themes of mental health in particular, where it's less dictatorial, where I'm telling you you are mad, and I'm telling you I'm classifying you according to what this book, which is written by experts, quote unquote, who've never experienced it, tells me to do. So
Exactly.
I think, yeah, so this is kind of the ground changes from an overarching theme, I think, in the times we are, that it's more about working with someone.
Yeah. And I think it's also incredibly important for patients to be able to see that, to see somebody who has navigated very complex mental health difficulties and come into the NHS in a high banding and have a good career, a job, a life. That actually you can kind of transition these difficulties. And I think that's really important and empowering for people to see.
We're talking about helping service users or patients or even colleagues. Tell me a bit about, I'm asking you in particular, how we can take care of ourselves. I feel most mental health professionals, there are psychiatrists, CN, etc. You would, there are difficult themes, there are difficult emotions that you're exposed to day in and day out. And I think it'd be kind of naive to think that as humans, it doesn't affect us. How do you, once you finish, how do you make sure that you have a good work-life balance?
So for me, I am a parent, and so I kind of finish work and I jump into a different role. So that helps that I'm able to kind of almost kind of compartmentalize different aspects of my life. I enjoy doing mindfulness. There's a under Keeping Well, which is available to any CNWL staff, NHS staff. You can access Keeping Well, so they provide online mindfulness sessions, and they run, I think, 3 times a week at various times and on different days. So I would encourage people to attend that. Sometimes it's for half an hour, and just having half an hour in your day to just unplug and get in touch with where you're at. I find that really powerful. I like swimming. I like being in another world. I find being under the water like another world. That helps. Talking as well about what's going on with supervisors and colleagues helps. And socializing is important. Having a life, having things to look forward to, annual leave booked regularly, that is important for me. Knowing that, okay, it's only another couple of weeks and I've got a bit of time off again.
Yeah, I think just for any doctors or trainees listening, one key insight or one key learning for me, one key takeaway was affective dysregulation. What does it look like? I was like, oh my God, I'm seeing so many people with like rapid switching bipolar disorder, and that's actually one of the classic, what should I say, conundrums where there is a lot of what bipolar is easy, where anything that's switching is just bipolar now. But in reality, the affective dysregulation, the effect is still what you're seeing on someone's face. A range of emotion is still messed up, but that you should think about complex emotional needs. You should think about that symptom, and it's easy. I feel like a lot of trainees at these doctors who are coming through will probably be exposed to the same question I'm saying, where is this part of complex emotional needs, EUPD? Is this a type of bipolar? They already have a diagnosis of bipolar. So challenging some of those ingrained and entrenched ideas, I think, is part of the new wave that we have to understand.
Yeah, very much so. I think we often come across patients that have both diagnosis, which would indicate sometimes that there's maybe the jury's still out. I think sometimes my experience has been is patients would rather identify with having bipolar than EUPD. Sometimes because that means that there is treatment and medication. There's kind of more and more people are moving to, gosh, if it's EUPD, then there isn't medication that's going to help you with that. So people are left in distress, and kind of it's preferable to have a diagnosis where you can get medication for some people.
I think we're pretty much out of time, Josie. I know that you have a unique service that you offer. That CN service, I think it's a very welcome addition to the CMHT. And also, I know this is probably one of the more difficult episodes because there's so much narrative around EUPD and complex emotional needs. I don't want to use the word controversial, but I would say that there's a lot of narrative. Different people have different approaches. And I think for me, apart from learning about the clinical knowledge, having that conversation was something which I learned today, and I feel like I learned from you generally when we were working together.
Thank you. One thing I would say is what's really important to know is that on LDZ, which is the Learning Development Zone, which everybody who is employed by CNWL has to go under, there is a training called CUF, KUF, Knowledge and Understanding Framework, and I would encourage everybody to do that training. It's training that is facilitated. One of the people is an advanced lived experience practitioner, and it's about understanding personality disorder. People have, yes, sometimes very unhelpful views about people with complex emotional needs or don't really understand much about it. So lots and lots of encouragement to please do your CUF training. It can be really, really helpful.
So Josie, there was this booklet which I found very useful. I also recommended it to my service users.
Meeting the challenge, making the difference.
I will see about, I'm not sure whether I can paste links in, but if we can kind of include this powerful induction booklet, I think we'll leave you some links. Just want to say thank you, Josie, for your time.
Thank you very much for listening, everyone. Goodbye for today, but welcome to the team. And if you have any further questions or you'd like to discuss a referral, please don't hesitate to make contact.
Yeah, in just the same vein, just to kind of ease myself and Josie into speaking freely, I would like to say that whatever we talk about today is a general discussion and shouldn't replace any medical advice. The purpose of this recording is educational, motivational, maybe make you feel a little bit less anxious about joining a new team and understanding its facets.